group, it's time to wake up. Because if you use the Google or ChatGPT and you want to care about prostate cancer, which is what I'm going to talk to you about, it's really our first foray into using this exciting new technology with this idea, is that you should care if you're the men in this room. If you're not the men in this room, you might be taking care of these people, so you should care for that too, because we know how man flu goes. And so we have 300,000 new cases in just 2024 alone. We're doing pretty good with treatment, but this isn't just a US or North American problem. It's now becoming a global epidemic. And so while we can do better at therapies, we still have 1 in 7 men, sorry guys, that are getting diagnosed. But there's really good news. We've done very well thanks to people in this room. So what you can see is a lot of the sequencing has allowed us to kind of get better with treatments. So in the first category, this just kind of walks you through how we do kind of treatment in prostate cancer. So if you have a BRCA mutation, BRCA isn't just for ladies anymore. So BRCA2 actually is your germline risk. It actually elevates your risk, but it allows us to give you targeted therapies. We do the same thing, even though prostate tumors are not as hot or as immunoreactive as kind of breast tumors, but we can walk you through that and do some staining and think if you're eligible for immunotherapy, so that's one. But really our last chance for romance, guys, so don't be afraid of the word, it's a chemical castration. And so one unique thing about what happens in prostate tumors is we take advantage of the idea that a tumor starts to express androgen receptor, and so it allows us to give us a better targeted tool. But it's your last chance for romance. If that doesn't work, so pay attention, because we really are thinking about AR a lot. If that doesn't work, you really have bad prognosis. And right now, we don't have a huge ability to really subtype that. So why do we even think about prostate cancer? I kind of set up Illumina to fail, if I'm honest. So we've been doing a lot of single cell in this. We've been doing a lot of other types of spatial technologies. And the interesting thing, which people don't talk about because we just put up the slide and we show you the pretty data, is that when you get blocks of prostate cancer from pathology, there's literally 8 blocks that you get before you actually get one that has cancer in it. So as you can see from the left-hand side, you can get very dense kind of tissue blocks, or you can get very diffuse. So a lot of times, even with path review, by the time you've gotten it, you actually have ones which have a lot of normal. So if you don't have a huge capture area, you can imagine that you're missing a lot of information. And I'm Canadian, so it's like a missed shot on goal, right? You get one chance for romance, and it's gone. And so what we really were able to see from this, one, you have, obviously spatial was the way, because we really have kind of the chance to actually not just ascertain big chunks of tissue, we can actually ascertain normal versus regular adjacent. What you can see is we do a good job. So these are samples that we know have not done well in other assays. And we're getting pretty good transcripts even. So normal will be the place where we don't expect a lot of transcripts, right? We don't expect it to be as high, so that's the yellow part. And you can see from even these 2 tumors alone, what happens in kind of these sequencing in any spatial is what you want to be able to do is capture transcripts at low levels as well as transcripts that are highly expressed in tumor. And with a lot of the other technologies, sometimes you get the extreme. So you get to kind of augment the really high elevated ones and you lose the low ones. So we can get both. And what's really important for this is we did not so great in other assays because we weren't really able. So you see with the normal adjacent, you get lots of ductal structures. So the cell segmentation becomes very important. Putting the transcripts in the right cell at the right place, one, from all the single cell we know is important, and 2 is really, we're able to capture that very well in this new assay. So what does that mean? So this is across the whole data set. We captured over 60,000 RNA features in something that we really couldn't get anything out of. So these are not ideal samples, but even as Nick showed, even with not ideal samples, we captured a lot of features, and that is really because we profiled 4 million cells, right? So what this large capture area allows us to do is really start to dig in to kind of more and more kind of data out of it in a meaningful way. So what you can see on the right-hand side is we get lots of the protein coding. We also don't dump a lot of reads, right? So that's going to be a big question for everybody. You've got to sequence it a lot, but all the sequencing that you're getting is really high quality. So for a sample that we normally get 100 to the highest we've ever gotten is 200 genes per cell, we're at about 1,000. So is that true? So the left side is just going to tell you we get consistent representation regardless of the feature types across the samples. And that's independent of the tissue size or the coverage, at least in this study thus far. But what I really want to show you is that graph on the right-hand side. So the blue is what we already talked about, the coding RNA. But what's really interesting is I'm going to walk you through why the non-coding RNA matters and why it matters specifically in this technology. And so thanks to everybody in this room, myself a single cell enthusiast as well, if you look at the top left side, that's single cell data, where we've been able to capture kind of these link or long non-coding RNAs that are very specific to the tumor alone. And is that, I'm here to talk about the clinical applications of these things, right? Is that actually clinically applicable? It's already happening. So on the bottom left side, you'll see that those are actually mutations that we're finding that are very specific to prostate cancer alone in long non-coding RNAs. And does that matter? Yes, because the side beside it is PSA3. PSA3 is where you gentlemen go and pee in a cup, so we don't have to go and be super invasive with you, and that's how we'll actually first determine if you have prostate cancer. It is usually when the tumor is super aggressive already. We also use it to see whether or not the cancer is going to come back. And when you can see is actually we're not very good at it. It's not super sensitive. So this long non-coding RNA PCA3 is actually super sensitive. And we know that because mechanistically, it actually regulates that one receptor I told you about, which is androgen receptor. So why does that matter? I haven't even shown you the pictures yet. So the pictures really show you that if we're only using tumor epithelial cell markers, right? So this is a pretty typical place and space by which you see the tumor. So when I showed you that high sensitivity, we can detect PCA3 prior to PSA3, the canonical test. So these are now clinically diagnosable tests. You have to pay more money for it, guys. So, but that PCA3 test is actually seeing recurrence before the standard testing. And that's likely because what you can depict and see very nicely in the spatial is it's not just localized to the tumor itself. And we see lots of beautiful talks that it's not just tumor proper, but what are the cells beside it? They're always in some kind of in-between stage of like, I'm not completely normal, but I'm on my way to tumor, and we can see this beautifully in this data. So that's kind of the clinical diagnostic application. I'm going to walk you through a very specific treatment application. So back to, again, don't be scared, guys. It's a chemical castration, so don't be afraid. But it works for you, right? So what we're really trying to do is that top part of the curve, is if your tumor is responsive to androgen, we want you only to be that one type of clone so that we can attack you with this androgen deprivation. But what we're really concerned about are the guys that you write last chance for romance, there's no other treatments for you, is if you don't respond to that and we've given that to you, what we've actually done is make your tumor more heterogeneous. And that's because we've made it become this cell type called a neuroendocrine cell type, which is more stem-like. And what you can see in the picture, now you have purple, you actually have purple, red, green. You have so many different clones in there that it's very hard to attack and becomes treatment resistant. So what did we actually see? On the left-hand side, I'm going to give you the clinical data. And so we know that on the left-hand side, this guy responded very well to androgen deprivation. And so prior to that, right, he still has a lot of tumor cells. Those tumor cells are different types of tumor cells. They're tan, they're yellow, they're purple. But on the right side is a guy that is non-responsive. And so he's somebody who has a very different tumor microenvironment. And so what you can actually see is that he has a lot of fibroblasts in there and very discrete populations of epithelial cells. But most interesting, we're going to take a deep dive into the macrophages. So not only is his tumor looking different, his composition of the cell types that he has in there, but back into that macrophage population, because now we can do all the single cell, but also the cell neighborhood analysis. We can talk about how those macrophages only like to live around fibroblasts. They're not doing their job in getting into the tumor. And so these are likely because we've driven it and given him treatment that made him more resistant and made the tumor more aggressive. And so if we go back to those markers, I'm going to teach you a little bit of the prostate biology. I'm bringing back the same marker, MSMB. So we both know these guys have cancer. We are using that. We know that's a tumor. Interesting, even if we look at PCA3, we see a little bit of that. But those neuroendocrine cells, which are less than 1% of the population, they're almost impossible to find in the single cell data. And what you can see in that castration-resistant guy, right? We gave him androgen. So we gave him androgen deprivation therapy. So we reduced his androgen, and we literally made it worse for him because we drove these neuroendocrine cells and fed them to come back on, and now this guy is not going to have any ability to try and resist treatment. So he's already resisted the last treatment we have for him. And so, and I'm perfect for timing, what I really wanted to show you is that what we don't currently have is, even in your last chance for romance, we're giving a patient a treatment that we haven't subtyped yet, right? So we walk you through, we gave you good genetics. We said, okay, if you have BRCA, then we're gonna give you something that attacks cell cycle repair. But once you get to like androgen, we're just gonna give everybody it. And what happens is when you do that, when you give the androgen deprivation treatment, you literally push them into a pocket of things that we can't actually ever push them out of. And so but we do have a therapy for that. We actually have a radioligand therapy, which we can actually attach directly and try and target those CHGA cells or those neuroendocrine cells. But that is not actually what we're currently doing. And I think this is really, convincingly, I always say this, that my husband thinks tuna and chicken are protein. But it's the first time I can give talks to someone like that, because he's not incorrect, right? Tuna and chicken are protein. But really doesn't have an understanding of RNA or gene expression or DNA sequencing. But when he can see these pictures, you can see even in this patient that their tumor microenvironment are actually the yellow and the red cells. And we can actually start to dissect that and see why people aren't responding in real time. And given that I'm at St. Jude and we do real-time kind of patient treatment, it's really important as we're taking these biopsies to be able to properly stratify these populations.